momentarily. Just hang out and we'll be right back with you. Thanks for joining, everyone. We'll be getting started momentarily. Hello, everyone. Hello and good evening to each of you. Thanks so much for joining us tonight for Ask Me, our educational webinar series. My name's Audra Hines, Vice President of Care Services for the Golden West chapter of the ALS Association. We could not make programs like this one tonight possible without generous donations to the Golden West chapter. I want to thank our lead sponsor for the Ask Me series, Mitsubishi Tanabe Pharma America, as well as our special donors, including the Ron Malone family and the Morris family. We're truly grateful for these tremendous contributions from our strong partners and amazing individuals and families like these. As a person living with ALS, or as someone who loves and cares about someone with ALS, we know that new symptoms and challenges related to the disease arise on a daily basis. It's critical to have the right people providing the right information that's easily accessible, including having the most qualified care team, in order to adequately navigate a variety of changes. As a part of the menu of programs and services offered, the Golden West chapter offers referrals to some of the top ALS centers in the country for specialty multidisciplinary care and clinical trial opportunities. We also offer a host of resources and referrals in your community. When it's time to understand how to find new medical equipment that's been suggested and prescribed by your care team, our staff of care managers will work to find a piece of equipment in our loan program if your insurance won't pay for it. When you need to meet other people who are managing the disease too and have as many questions and fears as you might, our team is here to suggest a number of support groups or other ways to connect with each other. If you're wondering what resources might be offered to family members, caregivers, or kids and teens who are helping their loved one have the best quality of life with ALS, our care managers have a lot of ideas about how to help. To learn more about the Golden West chapter and the multitude of services we provide, please visit alsagoldenwest.org for more information. In honor of National Nutrition Month, tonight we're bringing a presentation and discussion to you on a relevant and very important topic to many people living with ALS. Our team often receives questions about nutrition and ALS. When should a person consider a feeding tube? How does it work? How much will my family need to help me with this? And a host of other questions. And in order to provide some clear direction and guidance on this subject, as well as answer many of your questions, tonight we've invited two members of the Cedars-Sinai ALS Clinic team. Catherine Goebel and Tanya Bitcon are clinical dietitians who work frequently with patients with ALS and their families. I'm so thrilled you could join us tonight, Catherine and Tanya. If you want to pop your cameras on, that's perfect. And I'm going to let you take it away with your presentation.
All right, thank you for that introduction. I'm Tanya. I am the registered dietitian covering our ALS clinic here at Cedars-Sinai. I'm very excited to be speaking on this subject today with all of you because in our clinic, I'm often working with patients really within the whole spectrum of ALS, as have just been diagnosed recently, to people who've been living with ALS for years and years and everything in between. And my main focus is to help our patients maintain good nutrition as symptoms progress. And this includes a discussion of feeding tubes and helping our patients make the decision whether it's something that's right for them. And so I'm excited to kind of go through that with everyone here today. Next slide. We don't have any disclosures to report, and we just wanted to also note that we don't endorse any particular brands or products. We have some images as examples throughout this slide deck. Next slide. All right, and our objectives today. First off, we hope that everyone walks away with a better understanding of some of the nutrition challenges that people with ALS may face. We also want to go over the purpose of a feeding tube and indications for placement. And that's going to be what I'm covering. And then I'm going to hand it over to Catherine, who is going to talk more about the process of feeding tube placement, aftercare, daily use, all of that. And throughout the course of this discussion, we're really trying to answer the common questions and concerns that our patients with ALS are asking us all the time regarding decision-making and life with a feeding tube. So we hope that this is a helpful presentation for everybody. Next slide. Okay, so listed here are just some of the ways that the symptoms of ALS may impact someone's nutrition. And it's important to note that, you know, obviously people with ALS are not a monolith. You have a lot of different types of symptoms. There's a lot of differences in terms of progression. So this isn't an exhaustive list, and not everyone with ALS is necessarily going to experience every single thing that I'm talking about, but these are really common challenges, okay? And I really also hope to highlight the benefit of a multidisciplinary approach, because although I'm the dietitian and my focus is nutrition, I am definitely not the only person on our team that's making an impact on our patients' nutrition. It really takes a village with our doctors, our various therapists, nurses, support staff. Everyone kind of comes together, and that allows us to help our patients meet these challenges as effectively as possible. Next slide. All right, so when we're talking about eating, the first step is actually getting the food, right? So accessing the food, bringing it from the grocery store to your home, cooking it, getting it on the plate. So many of our patients in clinic with ALS experience things like lower body weakness, lack of coordination, and it really makes getting from one place to another more difficult. So it can become harder to navigate the kitchen. It can be more difficult to go grocery shopping. And as symptoms progress, they'll usually work with our physical therapist, maybe using tools like walkers or wheelchairs to help them get around. And we will also frequently discuss things like grocery delivery services or food delivery as a great way to cut down some of the mobility required for eating. And some of our patients have been able to take advantage of programs like Meals on Wheels, working with our social worker to see what they might qualify for. So once food has been cooked and made it to the plate, that's where self-feeding comes in. So that really, in a nutshell, is cutting up the food into bites, lifting the food to your mouth. So this can become increasingly difficult for people with ALS who might have weakness in their hands or arms. And, you know, this can increase the time and effort it takes to get through a meal. Often when doing a diet history, we'll start seeing, you know, portion sizes are getting smaller because it's getting harder for someone to feed themselves, and they might rely more heavily on their caregivers to help feed them. And one of the things that's been helpful for some of our patients is working with our occupational therapist to find maybe different assistive devices like a robotic feeder or specialized cutlery that can help make self-feeding easier and help them, you know, eat a better portion of food with less effort. All right, next slide. All right, so once the food has made it from the plate and into our mouths, up next is chewing and swallowing. So for our patients that have bulbar symptoms, they might have more difficulty chewing food, moving it around their mouths, and eventually swallowing the food. The whole process can become more tiring. It can take longer. And if someone starts to experience things like choking, it can cause a lot of anxiety, understandably so. So if if food goes down the wrong pipe and food or liquid ends up in the lungs, it can cause infection, things like pneumonia, and so that's not good, and it's a scary situation. Our ALS clinic speech language pathologist will be regularly assessing people's swallowing function and making recommendations for some changes that they could make to make the process easier and safer. So if someone is having trouble swallowing liquids, then sometimes we might use a thickening powder to help slow things down, make it more viscous and easy to manage. If someone's having trouble with solids, you might talk about avoiding certain textures that are difficult, like crunchy or dry textures, moving more towards small pieces of food, and eventually maybe more of a pureed or liquid diet, depending on the person and their swallowing abilities. And this also includes medications, right? So if someone's having trouble swallowing medications, that can be, really difficult. They usually will speak to a pharmacist to see if medications might be able to be adjusted. So instead of having to swallow a large pill, maybe there's a sublingual option or a liquid option, or et cetera. So there are some things you can do if swallowing medications is becoming more difficult. And in terms of respiratory function, you might be thinking, oh, I didn't know that breathing was part of the eating process, but it definitely is, and you can't swallow and breathe at the same time. So for our patients that are experiencing respiratory symptoms, they tend to work much harder to breathe. They need to catch their breath after expending even small amounts of effort sometimes. So you get a situation where someone might take a bite or two of food and then have to take a break, catch their breath, right? And so you have to eat very slowly and carefully, again, to try and avoid breathing and eating at the same time, which might cause food or liquids to go in the wrong pipe. And this is, again, increasing the time it takes to eat, increasing the effort, increasing anxiety around eating. And while this is happening, the food is getting cold on the table, not as appetizing. Next slide. And finally, food is never just food. So it's really often about the social and emotional experiences we have with food. So eating a traditional holiday meal with our families, having happy hour with friends, popcorn at the movies. Really, a lot of our experiences with food are social interactions. And what we find sometimes is that a person with ALS who's having more difficulty eating might miss out on some of those really meaningful experiences. And that can really take the fun out of eating. It can turn what should be a celebration of food into more of a chore, right? And, food also serves as an emotional crutch sometimes. I'm sure we've all had a bad day and want to treat ourselves to a slice of pizza. So some of our patients with ALS aren't able to indulge in those kinds of foods. Maybe their favorite foods are no longer safe for them to eat, which of course can take a toll. So it's really not surprising that a lot of the patients we see in clinic are reporting reduced appetite, reduced enjoyment of food and meals. And one interesting thing I wanted to mention too is that research has actually shown that we eat more calories. We eat much more in large groups of people in social settings. So if you're not eating that with friends at happy hour, if you're not eating a big meal with a lot of people, you might be eating smaller portions. And a lot of the foods that we eat in those situations tend to be higher in calories too, right? So a Thanksgiving meal is going to give a lot of calories. going out to dinner tends to give you more calories than eating at home. So next slide. So these are all some challenges that might cause someone with ALS to take in less energy. So they're all promoting a calorie deficit, okay? But that's really only half of the equation because on average, it's been shown that people with ALS actually burn more calories than you would expect. They have hypermetabolism. That's just a fancy way of saying that if you were to take someone who has a diagnosis of ALS, and then you were to take someone without ALS, and you were to match them height, weight, age, gender, everything, on average, the person with ALS is going to be burning more calories. So it's no wonder that I'm spending a lot of time with our patients trying to increase the calories of their meals. So we might switch from having some fruit for breakfast to maybe trying to eat something a little bit heartier. And we'll talk about ways to increase calories, like adding extra butter and syrup and delicious things, or maybe having a protein shake on the side. We're trying to get ahead of that hypermetabolism, and we're trying to get as many calories into each bite as possible, because if someone is having more trouble eating and they're taking fewer bites overall, we have to make those bites count. It's also important when we're trying to help someone increase their calorie intake that it doesn't add extra time and effort, which is why protein shakes are often used, just because they tend to be easy for people. They don't add a lot of time and effort when it comes to food, accessing food, chewing and swallowing a little more, are a little easier with protein shakes usually. Next slide. Okay, so because we have a situation where the symptoms of ALS are causing someone to eat less, right? Food's less enjoyable, it's more challenging. They also have hypermetabolism, causing them to burn more calories. It's no wonder that ALS is a disease that can really rapidly promote weight loss and malnutrition. It's important to note that people with ALS can lose weight not due to malnutrition. There's weight loss that comes inherently with the disease process itself. So the loss of the motor neurons, muscle atrophy will cause some weight loss, but malnutrition has the ability to really add fuel to the fire and accelerate that process. So let's say someone is experiencing weight loss, not getting enough calories and protein. When we're not eating enough calories, our body actually is going to start breaking down our own muscles for fuel, right? So you're going to be actually getting more muscle weakness, right? And that's not just affecting our limbs, our hands, it's affecting our breathing too, because the diaphragm is a muscle. So it's going to make you have more fatigue. It's going to maybe cause breathing to become more difficult, and those things make eating more difficult. Not getting enough protein weakens the immune system. It can cause increased risk for infection. It can really make it harder to recover from things like illnesses or surgeries. And it can increase someone's risk of developing wounds. When it comes to fluids, dehydration is also, a very valid reason to, consider nutrition support, because dehydration causes more fatigue, it causes brain fog, and can contribute to constipation. And if someone's constipated, they're uncomfortable, they're bloated, and that's not going to help anyone's appetite. So really, you can see that you can get a vicious cycle where you have the disease process itself causing weakness and muscle loss, and then malnutrition really adding on top of it. All right, next slide. So it's not surprising, given that vicious cycle I just talked about, that research tends to show a relationship between malnutrition, weight loss, and more rapid progression of disease. Research overall seems to show that people with ALS who have a higher body weight, that's a little more beneficial overall in terms of progression and survival. So compared to the population at large, a person with ALS is generally recommended to have a BMI of over 25. So BMI is just a ratio of height and weight, and you arrive at a number, and that number is categorized how it's shown in this table. So 25 is actually the start of the overweight category, and that's what we're usually shooting for in clinic if possible. If someone's weight is already over 25, then we'll usually recommend that they try and maintain that weight. We don't recommend just continued weight gain on and on, because at a certain point, you might have a situation where having a larger body can contribute to, decreased mobility, can make it harder to breathe, transfers can become really difficult, and we don't want that. So really, we just focus on BMI of over 25 for most people. Next slide. All right, so I hope by now I've kind of established some of the ways that the symptoms of ALS can really impair someone's nutrition, cause malnutrition, and how important it is to try and avoid that vicious cycle of malnutrition. Along the way, we've discussed a lot of different helpful tools like the protein shakes, the cool robotic feeder, the thickening powder, but that brings us to the next helpful tool, the star of today's talk, the feeding tube. Next slide. So in clinic, we often just call the feeding tube the PEG. There are actually a lot of different kinds of tubes, which Catherine is going to get into in a little bit, but the PEG is the most common one. It's a very simple device. It's a flexible tube. It's inserted through the abdomen, and it allows you to deliver nutrition in the form of formula straight into the stomach. Same thing with water, same thing with pills. So you're bypassing the mouth, you're bypassing the throat, the esophagus. Someone's not having to chew and swallow these things. It's just going straight into the stomach. And when I first show the feeding tube to someone in clinic who's curious about it, I feel like they're usually pretty surprised, because I think a lot of people's experience with feeding tubes is maybe from television or from people who are really, really sick in the hospital, and there's usually a lot of different tubes and lines. And in reality, you don't have to be hooked up to a big old machine that's taking up space in your room. You're not, hooked up 24/7, and it's not a big giant tube. It's just a little flexible tube into your abdomen. Next slide. So the purpose of a feeding tube is to help someone maintain good nutrition, right? Which obviously has benefits in terms of someone's energy, maintaining their strength, maintaining a healthy weight as much as possible. It really increases safety for people who are having trouble swallowing, because, you're not going to have as much food and liquid going down your throat, so that's fewer opportunities to choke or to aspirate or get respiratory infections. And because of this, that can really help someone's anxiety. It can really bring a lot of peace of mind to someone who's been spending a lot of time and effort trying to swallow safely. And of course, this will also frequently be helpful for caregivers and family members' anxiety as well, because it can be really high pressure to be trying to help, feed someone who might choke. That's a scary situation. I wanted to also talk about what a feeding tube doesn't do. So not the purpose of a feeding tube. It doesn't stop you from eating by mouth. So you can definitely still eat food with a feeding tube in place. The difference is that you don't have to. So if you are still safe to eat foods, or if you still just want to eat some food, you can do so. But the difference is you're not having the pressure of having to eat 100% of your calories by mouth. Instead, you can take a few bites of the foods that you still enjoy, and then get the rest of your nutrition or hydration, etc., through the feeding tube. It's also important to note that a feeding tube is not going to reverse or stop the progression of ALS. So I did talk about the ways that malnutrition can add some fuel to the fire when it comes to ALS symptoms, but that doesn't mean that by correcting malnutrition, we're going to be changing the nature of the disease. And sadly, the disease is progressive. And so even when we correct someone's nutrition status, that doesn't mean that their symptoms are going to improve. And finally, a feeding tube doesn't have to be permanent, right? So you can stop using it. You can decide to use it just for water or for meds, not for nutrition, or vice versa. It's up to you how to use the feeding tube. And if you decide that you no longer want the feeding tube, you can stop using it or have it removed. I think a lot of the stigma we see regarding feeding tubes is their use in situations like advanced dementia or comas, where they're, being used to prolong the life of someone who's not able to make their wishes known, who hasn't made that choice. And it's really being used to prolong what by most metrics would be a very poor quality of life. And that's definitely not what a feeding tube is for people with ALS. So the goal of a feeding tube is to improve someone's quality of life, to solve their problems. People with ALS are able to plan ahead and make the determination of how they want their feeding to be used, when they want it to be used, and decide at what point they would want the feeding tube to be stopped, to be removed or no longer used. Next slide. All right, so all this boils down to the question of today: when should I consider a feeding tube? And the answer is early. So it's really important for any person with ALS to be aware of the option of a feeding tube and start considering, if I were to have trouble swallowing, if eating were to become more difficult, would I want a feeding tube? That's a good question to ask, and start thinking about it early on. There's really a lot to be said for planning ahead, right? So there's a lot of benefits with placing it early as well. Before malnutrition and weight loss has really taken off, because then you're going into the procedure stronger, right? And of course, it's good to get a feeding tube placed before your breathing has declined. So in clinic, we are usually tracking someone's forced vital capacity, their FVC. And if that's declined below 50%, the procedure might be a little bit higher risk. Now, just because someone's lost weight or become malnourished, or because they have, impaired respiratory function, that doesn't mean that we don't place a feeding tube at all, because our team is really experienced in this, in particularly placing feeding tubes in people with ALS. And there's certain things that our team is able to do to kind of reduce the risks. So if you are considering a feeding tube and you have lost weight or your breathing function has declined, then I would just encourage everyone to go to a ALS center that has a lot of experience, like our center at Cedars, just to try and make that as safe as possible for you. And really, whenever possible, it's good to avoid an emergent situation, right? So by planning ahead, you can decide who's going to be placing your feeding tube. You can pick your team. You can decide when it's going to happen, and then when your feeding tube is placed, you can get acquainted to it gradually. So instead of waiting till you have lost a bunch of weight and you really need to get all of your nutrition and hydration and everything through the feeding tube, that can be kind of a high pressure situation. I think a lot of our patients like being able to get the feeding tube and slowly get acquainted with it, start using it maybe just for liquids, for meds at first, the occasional protein shake, and then they can increase their use of the feeding tube as needed. And before I hand things off to Catherine, it's just important to note that some people may decide that they never want a feeding tube, and that's totally fine. It's understandable. It's such a personal decision, and the pros and cons are different for everyone. So there's cultural, religious, and just personal beliefs that come into play, and people have different values when it comes to quality of life. So really our job in clinic is to educate our patients so they can make the decision for themselves, and whether the decision is yes, I want a feeding tube, or no, I don't, we support that decision. But let's say someone has been considering, okay, do I want a feeding tube? And maybe they're starting to have more difficulties eating. Maybe eating is taking longer, over 45 minutes. Maybe their swallowing is getting more dangerous. Maybe their breathing is getting, weaker. And maybe they're telling me that, you know what, I just don't enjoy food anymore. Then at that point, they might say, yes, I want a feeding tube. I think it's going to really help me improve my quality of life, give me time to, focus on other things, but rather than sitting at the table trying to eat. And when they say, yes, I want a feeding tube, that's when we put in a referral to our GI clinic. And they get to meet with our GI doctor and our awesome GI dietitian, Catherine, who I am going to pass things over to now.
Hi, everyone. I'm Catherine, and as Tanya said, I work in the GI department here at Cedars-Sinai. I'm a nutrition support dietitian, so this is 80% of what I do every day is helping people manage their tube feeds or their TPN. So I first wanted to talk about some more specifics about some factors that propel patients forward in deciding to get the feeding tube. So the first is, how severe is your aspiration risk? Aspiration is the abnormal movement of a foreign substance. It can be a liquid or a solid. While you're swallowing, if your swallowing is impaired, those foreign substances can get into your lungs. Even if a patient doesn't feel like they're actively coughing or acutely choking, you can still be micro aspirating. And that's where it's very undetectable by the patient. We call it asymptomatic. They don't feel it happening. They can still have these particles moving into their respiratory tract. So why does that matter? If you get aspiration, or if you experience it, I should say, you could develop bacterial pneumonia, which is very serious. Many people need to be hospitalized for this. And it can also lead to acute respiratory failure, where maybe somebody needs to go on a vent or spend time in the ICU. So it is very serious. So as swallowing function declines over time with ALS progression, the risk of aspiration increases. I found a few studies that show that dysphagia, which is impaired swallowing, is present in about 45% of ALS patients that have bulbar onset. And it's about 81% prevalent, 81% of patients with advanced ALS, regardless of where it presented, will develop dysphagia. So it's a pretty high number. Tanya already discussed how declining respiratory status might be a contraindication for PEG placement, so I won't go over that again. But then the next factor, which is important, is the patient's nutritional status. So if a patient becomes severely malnourished, their body may not be able to heal the incisional wound and the tract where the tube is placed from their external skin all the way through to their stomachs. So that whole tract right there has to heal. Our bodies need adequate protein, various micronutrients like zinc, vitamin C, and calories to be able to heal after a procedure like this. Studies have found incomplete incisional wound healing at twice the rate in a malnourished patient versus those that are well nourished. Not to say you can't heal. If you're malnourished, you can. It will take longer, and you may require more tube feeds or more supplements to do so. Other considerations would be if someone has had upper GI surgery of any kind. So just let us know, let your GI doctor know. And depending on what the surgery is, your anatomy may have been altered in such a way that a standard PEG placement isn't feasible. And you may need to go directly to a surgically placed tube, which I'll explain a little bit more about in a bit. And another is the presence of any comorbid conditions. Comorbid conditions are basically the existence of more than one disease at the same time. So that might be something that you were diagnosed with liver disease or diabetes before you ever were diagnosed with ALS. So for instance, if somebody has liver disease, they may have ascites, which is a fluid accumulation in their abdomen, and then you can't place a PEG. Usually in those cases, you may need to have the fluid drained. You may need a different type of feeding tube or a different option, based on something like that. So, hold on. Okay, there we go. So now I'm going to talk about the different tube options. So for initial tube placement, barring other concerns, a PEG tube is really what's preferred. The way that your gastroenterologist will place this type of tube is by inserting a scope with a light and a camera on the end of the scope. They'll insert this through your mouth and move it down into your stomach. They will then shine the light through your abdominal wall skin. You can see it right through, and that will tell them where the stomach is while looking on the outside. And with the camera on the inside, they can see exactly where in the stomach they are with the scope. So then they mark a little X on the area where the light shines through and it's a good place within the stomach. And they create a very small incision, just big enough to fit the tube itself. And I'll show you guys some tubes in just a moment. And then they place the G tube at the incision site and move it through the new tract all the way through to the stomach. And the whole procedure takes about 15 minutes. It's very quick. So I have a couple of tubes I wanted to show you guys. So this tube is the kind that the physician I work for likes to place on the initial PEG placement. So you'll notice down here, this is a little mushroom bumper. This is what will be inside your stomach. So this is inside your stomach and the rest of the tube will be outside. Okay, so it's a little dangly, it's a little long, but it's actually good for your first tube to have it long like this because you'll be needing to attach things to it. You'll be flushing, you'll be learning how to work a tube feed formula, maybe a pump or a gravity feed, depending on what you need. So it is easier to have this. You don't need any additional tubing. The other type of tube that you'll see frequently looks like this. And notice it doesn't have a bumper on the end. That's because you will be taking, it is actually a balloon bumper. So you literally take a little syringe, the doctor will do this, not you, and you fill it with air so that the balloon fills up and you fill it with water or air. And then it will sit just nicely in there again, like this, with this part hanging out. So at the end of each of these tubes, so the bumper is what's different in the two that I showed you, but the end, this part is what is very similar across all the tubes. So there will be a large hole up top for the feed. So that's where you'll be feeding yourself food. And then a little tube on the side, which is where you would give yourself medications. And you see it has these nice little tabs that you just open and close. When you're not using it, you can just go ahead and close it. And in this tube, the other one that I mentioned with the balloon, there's a third port, which is the port that I mentioned where you would fill the balloon up. So you day to day would not be touching this port. This is mostly for the doctor or a nurse to be altering. The nice thing about the mushroom bumper tube is that it can last for years. I've had some patients with a tube stay in there for 2 years, and it can function still really well. The tubes with the balloon are a little less durable. They will maybe last 3 to 6 months. What happens is the balloon it's such a thin material that it actually degrades over time. And so slowly what's in the balloon starts to leak out. And as the balloon gets smaller, you can imagine there's no more anchor there. So it can fall out, it can start leaking, it can do all these different things. So there's pros and cons to having a balloon versus the mushroom bumper. So let's see. So the other type of tube is a tube placed by interventional radiology, IR. I personally don't work with any interventional radiologist, so I won't go deep into that, but you may be someone who doesn't qualify for a PEG, but you can get it placed by interventional radiology instead. Surgery can also place a G tube. Again, I don't know a ton about the techniques of that. I am the PEG person, but each surgeon has their own way of doing it. Once the tube is in place, the rest of the stuff I'm going to talk about is very similar no matter what kind of placement you have. And another type of tube I wanted to mention is a PEG-J. So it's placed just like a PEG tube, except that there's some extension tubing that the doctor will place on the inside of your stomach, so you won't see it or know about it. But it actually goes past the stomach and into your jejunum, which is like one of the first parts of the small intestine. And the tube looks, I don't have an example, but it looks very much like this, and it has another port, and they'll be labeled G and J. The G means it's going into your stomach. The J means it's going into your jejunum. So the reason that someone would have this type of tube placed instead of just the standard gastric tube would be mostly because of tolerance issues. So maybe someone has uncontrolled nausea or reflux, vomiting, really any GI symptom that couldn't be managed appropriately with changes in the tube feeding formula, regimen, or through medications. The drawback to the jejunal feed is that you can only administer this type of feed with a pump. You can't give yourself bolus, which I will explain shortly. So it just basically means that you have to be connected to a machine for several hours for this type of feeding, which is why we don't just give it to everybody right off the top. It's much more convenient to feed into your stomach. And in our program here at Cedars, we usually start off with this long dangly tube that I showed you. And then after 8 weeks, once the tract has healed, the physician will exchange that tube for a low profile tube or a button or a Mickey. You may have heard these terms before. And it's very, very tiny. Tanya, do you have an example? Because I actually couldn't get one in time for this. But it's essentially, it's a very small tube. It literally just sits like this far off the surface. And then what you do is you attach extension tubing to it when you go to feed or give yourself meds or fluids or something like that. So now I'm going to talk about placement optimization. So now that you've decided to move forward with the tube placement, you want to make sure you've had some good bowel movements at least the day before the procedure. And the reason for this is because the colon, if it's full of stool, it can take up a lot of space in your abdomen and potentially cover the best window for where the tube is placed. It can also shift the location of your stomach so that it's sitting in a higher place than it usually does. And we don't want to make an incision in a place where your stomach doesn't usually day-to-day sit. So make sure you take some Miralax or Senna or an enema and have a bowel movement the day before the procedure. So onto the procedure itself, I'm just going to cover a few common questions that I get because people are worried about these things, understandably. So you will be sedated for this procedure, and you'll be closely monitored by an anesthesiologist. They will determine the level of sedation you need, but generally they use moderate sedation rather than general anesthesia, kind of like what they give for colonoscopies. In the GI lab here at Cedars, we usually use a laryngeal mask airway, which I have pictured here, instead of an endotracheal tube when we do this procedure. So you can see that it actually doesn't enter the trachea. It just covers the outside of it. So this actually lowers the likelihood that you're going to cough during the procedure. It lowers the likelihood that you're going to have oxygen desaturations. And it also prevents sore throat, that many people experience with the endotracheal tubes. So the doctor that I work for tries to place the tube in the antrum of the stomach, which is the lower part of the stomach itself, closer to the pylorus, which is where the food leaves the stomach and enters your small intestine. So that's typically where the tube will sit on the inside. And then she also tries to place it close to what we call the midline of the abdomen in order to minimize abdominal wall muscle cutting, which can be painful for a day or two after the procedure. We do provide medications for that pain. Sometimes people need antispasmodics, or they're okay with Tylenol or Tramadol to help with the pain, but it can be painful. And then the other thing is she likes to use a bar instead of a disc. And I have these two pictures here on the slide. On the left is the tube that has a little bar, like what I showed you guys earlier, like this. And this will sit at the outside of the abdomen. And it's this, you can see it's a very small, flexible little piece of plastic. And essentially, the benefits of this type of tube versus the one, as you can see on the right, which is a big disc, is that it can be very painful if you are sitting up and you have this large piece of plastic that doesn't accommodate like the rolls in all of the skin rolls in all of our stomachs when we sit up. And also it can be harder to clean around. Like you will never have no part of the skin around the site like not like exposed. So you basically have to make sure you get all the way up in there because crusties can form around the site itself, which is normal. You just clean that tube every day and it's just easier to do with a bar. So now we're going to start tube feeds. So it's time to select a tube feeding formula. And I want to start off this slide by stating that there's not a disease specific formula for patients with ALS. I'm asked this a lot. And as Tanya already discussed, there isn't a tube feed formula that is associated with stopping the progression of ALS. So what factors should we focus our attention on when deciding on a formula? So number one, I think probably the most important is tolerance. Most of our patients with ALS can tolerate a standard formula just fine, but there are a few nuances I consider. So should the formula contain fiber or be fiber-free? Sometimes fiber can contribute to gas, bloating, and diarrhea because the bacteria in our guts feed on it. Other times the fiber can help with constipation and promote a healthy gut microbiota. And it's difficult to know before you actually try a formula who will tolerate the fiber well and who won't. So sometimes the ability to tolerate fiber is also dose dependent. So I may start somebody off on a fiber-free formula and supplement with small doses of fiber, which you can administer through the G-tube. Another factor that I consider is the calorie density of the formula. So in this image here, you can see that it says Gevity, and then at the bottom it says 1.5 cal, and then the ones in the back say 1.2. So what this is, it's how many calories per milliliter the formula provides. And this ranges from 1 calorie to 2 calories. So I like to start patients off around somewhere in the middle, maybe 1.2, 1.5, mostly because people who haven't been able to eat properly for a while may have difficulty tolerating larger volumes. So the higher the number, the less volume you'll need. But you also don't want to go too high because you may need to give yourself a ton of hydration to make up for the fact that you're not getting the hydration in the feed. So again, I like to start somewhere in the middle. The next factor I consider is which formula is going to meet your calorie and protein needs the best. And that's really where the expertise of a dietitian is needed to compare and contrast all the different formulas out there because there are a ton. And the last factor I consider is the patient's diet preference. You know, if you were a vegan before your tube was placed and you want to continue that, I think it's important that we honor that. Compared to when I started as a dietitian 8 years ago, there are a lot more options out there on the market, and most of them will be reimbursed by insurance now. And infusion companies will stock these more specialty formulas. Okay, so I'm going to talk now about the ways we get the formula into the tube. So first and foremost, you do not need to use sterile technique to give yourself tube feeds. All you have to do is wash your hands like you normally would before you eat, and infuse with clean supplies, just like eating off of a clean plate. You don't have to use gloves. You don't have to use sanitizer, nothing like that to feed yourself. It's safe to do it the other ways. So the most common way I have here is a picture of bolus feeding. So basically you take a large syringe like this one, and you connect it to your feeding tube like this, and then you pour your formula into the top. You wouldn't have the plunger here when you do that, obviously. So you would pour it in like this, and then you can either let it flow in on its own, or you can put the plunger back in and slowly push it in. That's the most common way. Most people can tolerate this. And it mostly closely mimics like the way that we eat a meal. So you'll get your tube feeds in under like 15 to 20 minutes in one sitting, and then you're not hooked up to anything and you're free to go about your day until it's time for the next feeding. And then the second feeding method I have listed here is by gravity. So this is when you pour the formula into a bag like pictured, and you hang it up on a pole, like an IV pole that you might see in the hospital. and you allow the feeds to flow in slowly on their own. It can take an hour or so for a full feed to flow in, but the reason you may want to use gravity feeds instead of syringe feedings is if you have any negative upper GI symptoms with the bolus feeds. So sometimes people will have reflux or nausea or extreme fullness to the point where it's uncomfortable. So the gravity feeds allow some formula to be leaving your stomach at the same time it's coming in, so you avoid a lot of those issues. Another reason would be, some patients develop, issues moving their hands, coordinating the holding of the syringe and the pouring of the formula at the same time. So it's much easier to just pour it in a bag and hang it. And the last feeding method is by pump, which I mentioned earlier. So you set this up similarly to gravity feeds, and that you pour the formula into a bag, but then instead of the feeds flowing in by gravity, there's a pump that the feeds run through. And the advantage to this is that you can pick a specific rate. So it would be ideal for people who have major issues tolerating the other two types of administration. So in regards to a feeding regimen or schedule, this should absolutely be patient-centered, individualized, and can be changed easily. There's no right or wrong way to give yourself tube feeds. So as a dietitian, I'll usually help guide patients in somewhere to start and how to tweak things. But I definitely defer to their own lifestyle preferences and personal lives. So I've listed just a couple ways that people will give themselves tube feeds. So some people will eat their meal as they're able. And then whatever they weren't able to finish, they will supplement with some tube feed formula. Another way is to infuse the tube feeds in between meals as a snack. And a third option is to infuse the tube feeds at night while you're sleeping, but you need a pump to do that. Just a quick few notes on blenderized tube feeds. Some people don't want to use a commercial standard formula and would rather use tube feeds that are made up of whole foods that have been blenderized and don't have, additives and things like that. So there are pre-made formulas on the market that are being approved by insurance now. When I first started, again, insurance was not okaying these. And now I've seen all of them be approved. So I've listed a few here just for examples. All of these, with the exception of one, Nourish. So all of them need to be given by bolus through a G tube because these are whole foods that are blended. Easily the tube can become clogged. So you need to make sure that you're only administering it under those settings. Nourish is the one exception. Like I said, if you have a J tube or you're using a pump, Nourish will actually fit through that. I have many patients using that right now, so that's fine. You can also make your own at home. So there are a few options of how to do this. So one, you would use a commercial formula day to day. And then maybe for like a family meal or something like that, you would blenderize the food that the family is eating and infuse that with the family at the same time. And all you have to do when you do that is, make sure you have a heavy duty blender like a Vitamix, and make sure that you can thin out the formula so that it's a thin consistency. It's not thick and chunky, or else it'll clog the tube. And like I said, it needs to be bolus fed, so administer within 2 hours. You can only keep the food in the refrigerator for 24 hours. So you may prepare day by day for the whole day, but you can't do it like for the week, for example. And always follow the guidance of a dietitian. So free water flushes via tube, I know we're running out of time, so I'll try and be quick, but basically the tube feed formula alone will not meet 100% of your maintenance fluid requirements. So the dietitian will guide you in how much you should be flushing to maintain hydration. But I also tell patients to monitor this stuff on their own. So if you are only urinating twice a day, you probably need to give yourself some more flushes. If your urine is anything other than yellow to pale yellow, you probably need to give yourself some more flushes. And we often get asked about other liquids. Can you put other liquids into the tube? The answer is yes. Sometimes people will want wine or coffee in there. You can absolutely do that. I just encourage moderation, and that you don't count those types of fluids that are diuretics towards your daily fluid intake. This would be an extracurriculum. Another major reason for giving yourself flushes is to maintain tube patency. So basically that's a fancy way of saying to stop the tube from getting clogged. So a good rule of thumb is that you should flush with at least 30 mLs of water before and after using the tube for any reason. Regarding medications, so consult with a pharmacist about whether you have a medication that can be crushed safely or not. If it's a medication that can't be crushed safely, they may be able to switch you to a liquid form or a dissolvable form. And when you do crush these medications, you want to mix it with water into like a slurry and flush it into the tube. So if the tube becomes clogged, only use warm water. Studies have shown that Coke and juice and all these other things are not as effective as just plain old warm water. If you're not able to declog the tube yourself, then that's when you should see your doctor or come to the emergency room. So I have a few more tools here that I will really quickly go over, but basically it's for people who have difficulties feeding themselves over time, but still want to remain independent. So the first one right here is called the buckwheat, and it essentially holds the syringe for you so that all you need to coordinate is just pouring the actual formula into the syringe. The next one is the Bowlink Dream Cap, which is essentially this tube right here, and it connects to your tube feed, screws on top, and then instead of having to, again, coordinate with a syringe, you just turn this upside down and it'll just flow in. The Bowly bag is very similar, difference being that you can put your blenderized tube feeds in there and do the same thing as the Dream Cap. So last slide, I'll be as quick as I can. So you do need to follow up with your dietitian to adjust your tube feeds. Things will not go perfectly. What worked one month might no longer serve you the next month, and your metabolism and calorie needs will likely change over time. So they need to evaluate all these different things on the list. They need to watch your weight, how your clothes are fitting, laboratory values. A lot of patients with ALS will develop impaired glucose intolerance, which may mean that you need a different kind of formula to handle that. And then, of course, we want to know how you're tolerating the feeds. About 61% of ALS patients experience constipation. So we may need to add the fiber, like I said, or add a prescription medication, or increase your dose of the over-counter med that you're already using. And then also, we want to be mindful of what your physical and functional capabilities are. So somebody who may have started with syringe feeding has to move to a gravity feed. So we need to know, what's going on, and we need to be able to order those things for you. And then lastly, I want to know how you feel. Do you feel stronger? Do you have better energy? Is this interfering with your day-to-day life in a way that is not helping you? We want to know all of those things, and we can make adjustments accordingly based on what you report that we necessarily can't measure. And that's it. Here's some resources we have for patients. I really like the Olay Foundation. They have a lot of good material on there for patients.
Oh my gosh, you guys, this was amazing. Thank you so much. Do you mind stopping your share, Catherine? That way, when we do some questions, everybody can totally see you both. Leaders obviously knew what they were doing when they hired both of you. You guys are awesome. This has been a wealth of information. Thank you so much. Are you able to see that up at the top? Just stop sharing.
No.
If you scroll up, it should say, give you a stop sharing option. Just like put your cursor at the top.
Oh my God, I'm so sorry, guys. It's showing me new share, resume share, all the other kinds of shares.
Okay, well, we're going to go with questions. Maybe one of our other hosts can help bump us out of that. Okay, we do have some questions. I'd love to be able to get to these. Someone asks, if you place the tube early, perfect. If you place the tube early, does it need regular maintenance even though it isn't being used?
Yeah, so regular maintenance is I would say maybe flush it once a day. Just to keep the tube from getting sticky or, having juices that kind of flow out of it. Sometimes you want to make sure that you're keeping it open. So flushing once a day is fine.
Okay, perfect. That's helpful. Is the surgery, I think you actually.
Sorry, really quick.
Yeah.
You do still, at least early on, have to do the rotation once a day too, right? Is that something that we usually recommend?
Yeah, and you should clean the site every day, not the tube itself, but your skin, as small amounts of gastric juices can leak out, and that's normal.
Gotcha. Okay. No, that's great clarification. Thanks. I think you guys touched on this a bit, but someone's asking, is the surgery for placing the tube outpatient surgery? Is it a local anesthesia or general?
Yeah, so it is outpatient. I will say that we do give the option if a patient wants to be admitted overnight to be observed and for pain control, and also to be taught more about the tube if they're not feeling confident about it. And then you're under moderate sedation. That's what the anesthesiologist tells me. It's not general. So you won't, have something breathing for you unless you're already on a vent at home.
Okay, awesome. Another person asks, my clinic uses interventional radiology method. Any info on that?
I mentioned it, but I
Yeah.
don't have specifics other than to
Okay.
say, taking care of the site is very similar. You need to just wash it with soap and water every day, and then make sure you're flushing the tube to keep it open. And that's about it. Yeah.
And if you get if the tube becomes clogged, someone's asking, can you use the plunger to gently push like warm water through it?
Yes, that's what you should do. So I
Yeah.
usually tell people to take the warm water, push it in, and kind of let it sit there for a minute to kind of break down whatever's inside that's clogging it, and then just continue to push in slowly.
Perfect. And Catherine, would you mind just sort of re-showing the tubes?
Yes.
Just now that we can see you better, I think people will be able to see them. We got a request for that.
Yes.
Perfect.
So this is the one with the mushroom bumper I mentioned. And so this whole part will be outside of you from this little bumper part out here. And then this is the other one that has a balloon on the end. It's not inflated, but it would have like a little tiny balloon.
Okay, got it. Yeah, thanks. I see those a lot better. Someone's asking if it's okay to swim or take a bath with the feeding tube.
Yes. So I tell people after 6 weeks, you can fully submerge in water of any kind. So you can, take a bath. You can start showering the same day. The little amount of water that you get from being in the shower that might enter is totally fine, not an issue, just the fully submerged 6 weeks.
Okay, great. And the last question that I see here, at least as of now, is what types of activities might be problematic with the tube in place? Any special considerations around anything you could think of?
I'll let Tanya answer, but mine is none. Like I have patients who exercise, without ALS, they will run marathons with a tube. They'll lift weights with a tube. There's really no limitations for what you can do.
Great.
Tanya, do you have something else?
That's exactly what I tell people all the time, is it's not, going to take anything away from you. You should be able to do everything you could do before with the tube.
Okay, that's a great answer. If a person is still eating by mouth, what's the best method for calculating the supplements in the G-tube?
Mm-hmm. Yeah, I think that it is important to have a dietitian around to help you with this. But certainly, I would say your weight or clothes fitting is the best indication as to what you're doing, as to whether what you're doing is enough or not. So, maybe once a week, do a kind of assessment on yourself to see, hey, I gave myself 2 cartons a day. How do I feel? How do I look? Do I need to add more? And then you can add more.
Makes sense. And then go ahead.
The only other consideration is that's the best way to track, calories, protein, are you getting enough? But the formulas, there's a certain volume that you would get to meet like your recommended vitamins and minerals. So if you're only taking a small amount of formula, and if your oral diet isn't very varied, then it might still be beneficial to maybe do some vitamin, like a multi or something, but definitely talk to your care team and your dietitian to see if they would recommend it.
Okay, that's great advice. can I remove my tube if I no longer want it?
Yes, yes, absolutely. You can remove it anytime you want, really, and it will heal up quickly within a few days if you're well nourished at the time. If you're not well nourished, it will take a bit longer, but it will heal eventually, and it will leave like a little pea-sized scar.
Okay. And related to that, what advice do you have around securing the tube? What do you do if it comes out?
Oh, okay. So securing it are a few things. You can tape the dangly part, this part, you can tape it to yourself so that it's not like pulling and it doesn't get caught on anything. I have other people who purchase elastic bands that they wear around their waist area. And, you know, you can find them on Amazon. They're called like pregnancy bands, or they might even be called them tube feed bands now. So that's what I do. And then if the tube falls out, you can put it back in, or put something in it to keep the track from closing, because that track wants to close very, very quickly. And then get yourself to an emergency room or to your doctor if they're able to, because they can probably exchange it in clinic.
Okay. And last question, you guys both talked about this a little bit, but ultimately, we have a couple questions around whether this extends a person's life, right? Certainly we know it's offering the person nutrition, energy, sustenance. So from that standpoint, but ultimately, what would you say about that around life expectancy?
Oh, well, so Tanya and I talked about this before we had this presentation. So there's very good data that shows that patients with ALS that are not malnourished, their life expectancy extends between 2 to 9 months. So is it the tube itself that, you know, creates the life extension? No, but it's the correcting of the malnutrition which the tube allows them to do.
That makes a lot of sense.
Yeah.
Tanya, yeah.
And there is just, it's a really hard thing to study directly, right? Because of the ethical considerations, because people with ALS are so diverse in how they present initially, how they progress, the timing of the feeding tube. It's incredibly complex. So when you look at the data, it's very mixed. But like Catherine says, we know malnutrition is a problem, and we know a feeding tube can help with malnutrition. So it's definitely like a best practice.
That's great. I actually don't see any more questions, and I honestly can't thank you guys both enough for your time. This has been great. This is the first webinar we've done on this specific topic, and you both were just an absolute wealth of information. So I want to thank you both. I want to thank really everyone for joining us tonight. We're really grateful to each of you for your time and commitment and for being a part of our community. And once again, a big thanks to Mitsubishi Tanabe Pharma America for their support. Want to let you know our next two Ask Me webinars are scheduled for April 28th on respiratory care and May 25th on the importance of multidisciplinary care with the UCSF ALS clinic team. Please do join us for these great topics, and also a couple of events coming up as we're slowly returning to in-person events this year. We invite you to save a couple of other dates coming soon. We have a Jim Tracy 5K to defeat ALS, and our SoCal Ride, Hike, Walk to defeat ALS are both coming soon in the next couple of months. Please join us for a beautiful day outdoors at either of these amazing events and sign up today at the websites on your screen. As you know, philanthropy fuels absolutely everything we do, and we're grateful to committed donors who give generously throughout the year. To learn more about how you can support the valuable programs we offer, including programs like this one tonight, please visit our website at give.alsagoldenwest.org, and please watch for the short survey on tonight's presentation that you'll receive via email to help us plan for future educational programs. Thank you all again, and we will see you next time.